We are going to talk about cardiogenic and obstructive shock. Here are your objectives related to cardiogenic and obstructive shock.
Cardiogenic shock, like all other types of shock, is going to result in hypoperfusion and inadequate tissue perfusion. However, what makes cardiogenic shock different is you have adequate preload. Think about it with hypovolemic shock, whether it's hemorrhagic or non hemorrhagic. You don't have enough volume in your vascular space. You have inadequate preload. And look at septic shock with your distributive shock. Now, initially, you don't have an issue with your preload when you're in septic shock, right? And you truly don't have a true absolute problem. It's a relative problem. Think about the pathophysiology of sepsis. You're going to have that massive vasodilation, right? So your vessel is going to get bigger. And although your preload was adequate before the vasodilation, now your vessel's three times larger. So now, of course, that's not enough volume to accommodate that much larger space. So that's why with septic shock, we give fluids first generally, because we're going to increase your preload. So now that it is appropriate for that vasodilation. And if that doesn't work, that's when we move on to pressors. Now, cardiogenic shock, you have adequate preload. So we have to focus on other factors that affect cardiac output. So that's why our treatments are a little different. Think about it. What's your cardiac output? It's your stroke volume times your heart rate. Well, what's your stroke volume? Your stroke volume consists of your preload, aka your volume, your heart's contractility, aka the force, and the afterload, aka the amount of resistance your left ventricle is facing in order to pump blood back to the rest of your body. So, with your cardiac output, if you increase your preload, the volume, that increases the cardiac output, right? Yes. If you increase the contractility, that is going to increase your cardiac output, right? Well, afterload is different. Afterload is making it harder for it to do its job. So when our afterload is high, that decreases cardiac output. That one's different. So when we treat cardiogenic shock, you'll see that the treatments are going to be a little different. And that's because our preload's fine, and we have to focus on the cause of the decreased cardiac output. So it's going to be your contractility and afterload. We have to aim our treatments towards those factors.
We know that cardiogenic shock is going to result in decreased cardiac output despite adequate preload. So we know that cardiogenic shock is going to be caused by things that alter the contractility of the heart, so things that decrease the heart's ability to pump, and things that increase the afterload. So things such as myocardial infarction, because you can have damage to that pump. And this is going to be the most common cause of cardiogenic shock. But other things such as trauma, cardiomyopathy, myocarditis, arrhythmias, congenital heart diseases, and that postoperative period after cardiac surgery can put a patient at risk. And cardiogenic shock is going to present very similar to our hemorrhagic or hypovolemic shock, where we're going to have that central nervous system activating and compensating. And so you'll have that narrowed pulse pressure, you'll have that tachypnea, tachycardia. You're going to notice that the patient is going to have crackles in their lungs because remember, your heart is not pumping. So you're going to have that backflow of blood into the heart. Treatment for cardiogenic shock is going to be targeted at treating that underlying cause. And while we figure out what that underlying cause is, we are going to do additional therapies to support the body and improve that cardiac output. When I say the underlying cause, let's say a myocardial infarction is what is causing this cardiogenic shock. Well, our goal is going to be reperfusion. We need to get the patient to the cath lab. But in the meantime, we still need to support the body and do things to maintain perfusion, such as initiate oxygen. Patients may need to be intubated. Patients may require the administration of vasoactive drugs and inotropes. You'll see dobutamine, milrinone, dopamine used. And remember, at high doses, epinephrine can be both a vasopressor and an inotrope. You may need to use norepinephrine to support the blood pressure. And we said that with cardiogenic shock, you're having a pump failure. And because of this, this can lead to volume overload. So sometimes you may need to administer diuretics. You want to do very close hemodynamic monitoring, and you want to watch for those signs and symptoms of fluid overload. Sometimes you have to use something called a balloon pump, which is going to work to help support the ventricles until you can treat that underlying cause. Often you will see inotropes utilized in cardiogenic shock, such as milrinone or dobutamine. And dobutamine is going to be a popular choice for treating cardiogenic shock, especially post myocardial infarction, because dobutamine is going to increase that contractility of the heart, making it beat more effectively. And it is going to increase your arterial dilation. So you're going to get arterial vasodilation. And this is going to allow for those coronary arteries to be better perfused post infarction. And it is also going to decrease that afterload, which is going to help maintain cardiac output. But because dobutamine is going to cause arterial vasodilation, it can also lead to hypotension. Think about it, when your arteries get bigger, what happens to your blood pressure? It's going to decrease. Think about like how that septic shock presents. So sometimes when a patient is going to need dobutamine, we're going to need to start a vasopressor such as norepinephrine to cause a little bit of constriction and to balance out that cardiac output, if that makes any sense. You will notice that some sources are going to list obstructive shock as a subset of cardiogenic shock, but that's not exactly right. And I want you to think about why. Remember, our cardiogenic shock is going to be related primarily by pump failure. So the heart is unable to pump effectively. Although an increased afterload can contribute to cardiogenic shock, I want you to think pump failure. With obstructive shock, what's going on is you have a mechanical obstruction that is going to prevent the heart from properly filling or pumping enough blood. Obstructive shock is going to be caused by some type of anatomical obstruction of the great vessels of the heart. And I want you to think about what's happening. So you have an obstruction. So blood is not able to adequately flow through that area. So you're going to have that decrease in venous return or that decrease in preload. And because you have an anatomical obstruction, it's going to increase that pressure because what is the blood trying to do? It's trying to get past it. So you're going to have increased pressure in your ventricles, which are going to lead to increased afterload, which also decreases cardiac output. So things that can cause obstructive shock can be a very large pulmonary embolus. Think about it. You have that blockage, blood is not able to pass through that. You're going to have that backflow of blood into your systemic circulation. Cardiac tamponade, constrictive pericarditis, certain cardiomyopathies. And I want you to think about the symptoms that the patient will experience. They're going to have those clinical signs of shock, but a lot of times you're going to see that they're going to have clear lung sounds and they're going to have signs of systemic overload because you have that reduced venous return to the vena cava and you're going to have that backflow of blood caused by that pressure. So you may see engorged neck veins, you can see peripheral edema, and things of that nature. And the patient is generally going to be very hypotensive.
We all know that the heart is just a glorified pump, right? I mean, all it does is deliver oxygen and nutrients to your entire body and keep you alive still. So, in a nutshell, how does the heart work? By pumping. And what happens when the heart is unable to pump? You die. All right, now we're going to get into cardiac tamponade. So, we all know that the heart is going to lay in the pericardium. And there is going to be a small amount of visceral fluid in the pericardium. And this is going to protect the heart. It is going to provide lubrication and it is going to prevent friction and shearing and trauma. Now, it serves a great purpose, but remember, too much of anything is never a good thing. Have you ever been to a concert? Concerts are great. Like the atmosphere is awesome, the music be jumping, but the problem is there's no space. It can get so crowded that you can't even move. Well, that's what's going on in cardiac tamponade. Ultimately, cardiac tamponade is going to be caused by a pericardial effusion. And that's just an influx in the fluid surrounding the heart. Now, a pericardial effusion in itself is not a medical emergency, sometimes it's even self limiting. However, what happens when there's too much fluid to the point where the heart is compressed and it is unable to pump? Well, you have no cardiac output. So, what causes a pericardial effusion? Trauma can. Think about it. If you have trauma to your chest, it can cause a hemorrhage and that can increase the fluid around the heart, right? Pericarditis. You may see it in end stage renal patients when they have fluid overload. I mean, it has to go somewhere, right? You better keep those dialysis appointments. It can also result from infection, surgery, like any type of cardiothoracic surgery, because remember, that's a form of trauma, cancer, aortic dissection, a heart attack. All right, so let's talk about what happens. In cardiac tamponade, the compression is going to cause an obstruction, aka obstructive shock, right? Because it's going to prevent the heart from pumping, and it's going to compress on all four chambers, which is going to prevent the great vessels from delivering blood into your atrium. And ultimately, that is going to cause a pump failure. And that's why it can sometimes it's classified as a cardiogenic type of shock as well. But ultimately, it results from the obstruction. So let's look at your signs and symptoms. Obviously, you're going to have a decrease in venous return, right? Because you have that obstruction. So you're going to have low blood pressure. And remember, you're going to have that venous congestion from the backflow of blood because of the obstruction. So you're going to have JVD. You may be tachypnic, tachycardic, your normal signs of shock, because this is a type of shock. And now, you also, Beck's triad. This is going to be if you see Beck's triad, that patient is about to die if you don't act. Now, what is Beck's triad? You're going to have the JVD with clear lung sounds, right? Yes. Now, you're going to have hypotension, right? But you're going to have a narrow pulse pressure. Let's talk about that. Why is your pulse pressure going to be narrow? Remember, your pulse pressure is going to be the difference in your pressure when your heart is at rest and when it's pumping. So you subtract your dystole from your systole, right? So 120 over 80, the pulse pressure is 40. That's normal. Now, in cardiac tamponade, your heart is not able to pump. It can barely pump, right? So, of course, the pressure is not going to be much higher when your heart is pumping because it's not really pumping. And that's why you have such a narrow pulse pressure, because your heart ain't doing nothing. So, a lot of times it could be like 10 to 15 points. You could be like 70 over 80. Like, for real, it is insane. But you have no cardiac output. So, of course. And you're going to hear muffled, hard sounds. Why? Because you have so much fluid surrounding your heart. Let's go jump in the pool right now and try to have a conversation. I'm going to be a little muffled, right? So, those are your additional telltale signs that you are in cardiac tamponade. Now, obviously, your heart isn't pumping. It's like, let's tie a rope around the heart and see what happens. It can't move. So, you're going to go into cardiac arrest. So, when you do, does CPR work? Nope, it does not. Because what is CPR? That is a person taking over the mechanical function of the heart. And you still have the same problem. You trying to compress on the heart still has no space to pump. Now, you do need to start CPR, but in order for that CPR to work, you need to do a pericardial window at the same time. You need to drain the fluid from around the heart. That has to happen in order for CPR to work as a pump. Now, I've had cardiac tamponade patients and they are extremely unstable. So, if you suspect cardiac tamponade or you're showing signs of shock with Beck's triad, you definitely need to act, because our normal life-saving treatments, yeah, I can give you epinephrine and I can attempt to compress the heart, but it's not able to pump even then. You have to remove the obstruction. Like I said, with obstructive shock, you have to remove the obstruction. which will be done with your pericardial window. You may hear it called a pericarditis. Hold on, pericardiocentesis. I can never say that. I decided to practice, and it was an epic fail.
The end.